Our final speaker is Dr. Dave Thomas, a health scientist administrator at the National Institute on Drug Abuse, and we're so excited to have him with us today to share his work on NIDA's pain and opioid research. Dave?
Yeah, hi, it's Dave Thomas. Thanks for the introduction. Thanks for having me as part of this meeting. I'm going to keep it quick, keep it short. We're running late on time, so I'm kind of like less is more, I think we should take as an approach here. So nothing to disclose except I care about people in pain and also care about the opioid crisis. We at NIDA do both of those things. My talk's going to follow. I'm just going to go over how pain works and how addiction works real quickly and how they kind of intersect. Then I'm going to touch on a few of the things that we're doing at the NIH to address these problems. I don't have a lot of slides on that, but I'll just talk through some of that. And then I was asked early on if I knew anybody that could talk about alternatives to opioids, and the VR, virtual reality, came up as a possibility. And it's like, well, I've been promoting that at the NIH for the last 18 years. So I'm going to end with just zooming in on one potential alternative to opioids. So, but first, how the brain and pain work. So here's a brain. We're looking into there, and pain comes up into the brain and can cause the brain itself to get inflamed, can be perceived as pain. It goes up in pathways. But what happens is you have endorphins in your brain, and they get released, and they activate descending control of pain, and that can then reduce the pain. Sorry, I'm working on my animations here. This might be too complicated for this. So that's all fine and good. But then the way that opioids work is they mimic the effect of your endogenous opiates. They get released in your brain. They can activate your descending control systems of pain, and they can result in the pain going down. So that's wonderful. But the problem is when you give an opioid systemically, if you take a pill, it goes all over your brain. It doesn't just go to the parts that stops pain, but it goes all over the place, and it goes to places that are involved with addiction. And separating out those two is a key thing that we're working on, but is very difficult to do. And so you basically have two parts in your brain. This is real simplistic, but your prefrontal cortex can stop addiction. It's your brake, if you will. But then you have your limbic system that's kind of your go system. And when that gets opioids, it gets overactivated. And the part that stops your addiction, your prefrontal cortex, that's your impulse control, that gets minimized. So it's basically driving around with the accelerator down and no brakes in a car. So that's what we're trying to get at, and trying to find a way to reduce pain without activating this whole stop-go thing where a person gets out of control. So now let's go to a question. How many people in pain become addicted? I mean, this has puzzled us for a long time. I've seen reports anywhere from nobody or almost nobody, and that's part of the problem, to something like 40%. We just don't know. We don't have those studies looking at people transitioning from pain to addiction. We're starting to do research in that area. We're also working with the FDA and pharma to look at this question prospectively. If you have pain, you're not addicted, you start taking opioids for pain, do you start misusing? Do you abuse? Do you become addicted? Do you die? Do you actually have more pain as a result of getting the opioids? It's called opioid-induced hyperalgesia, and we think that might be part of the problem we have in America right now. So that's one set of studies we're looking at. I'm going to show some CDC data. You've probably seen them, but I think it's amusing and intriguing and disturbing all at the same time. This is the death rates in the United States in 1999, and you can see as we progress through the slides how things digress in our country, where there's more and more red, meaning more and more people are dying from opioids. And this trend has been getting worse and worse and worse. And when I ran this analysis, I threw in the 2016 data, which I haven't seen, but you can do it through the CDC site, and it was shocked because the red went down. It's like, oh my gosh, this isn't consistent with the data we've seen in terms of the increase in rate. Well, what they did, if you look down at the bottom, they changed the scale. So red now means 30 or above, not 20 or above. So not only is this not promising, they had to expand the scale because of the scope of the problem. So the problem is continuing. This slide was shown earlier in 3 waves, which I thought was a real intriguing way to do that and informative. But this goes out to 2016. So you can see the fentanyl is now the leading cause of opioid deaths, and heroin spiking up too. Fentanyl, 100 times stronger, 50 to 100 times stronger than heroin. It doesn't take much extra fentanyl to die. It just if you look at carfentanil, that's about 100 times stronger than fentanyl. So part of the problem is people are using heroin. It gets laced with fentanyl, which is relatively cheap to make, but if you get a little too much, you're dead. So if you look at, and this is SAMHSA's data, but this is transition from prescription opioids to heroin. 4 out of 5 people that start abusing heroin started with prescription opioids. It's prescription opioids is a clear step in the process. Not that they're in pain or the pain patients, but it certainly is part of the problem. And if you look at the opposite direction, 1 in 100 start with heroin and move to prescription opioids. That trend might be changing, by the way. There's some newer reports that more people might be starting with heroin, which we have to keep an eye on. But if that's true, there's another problem we have to deal with. The next slide, again, is just showing the data from the death rates from opioids. But then I superimpose how many people in the United States had pain, chronic pain, serious pain, daily pain. These are from the American Pain Society IOM reports. From 1999 to 2011, the number of people in pain in the United States doubled, which is odd because pain, we don't think it's contagious, but there's a pain epidemic expanding, and part of that might be, if you think back to the opioid-induced hyperalgesia, part of this might be people that take opioids for their pain, they get a rebound, which ends up causing pain, and then take more opioids. So for some people, there might be something of a vicious cycle. This is the concept. Short on time, don't want to get into it too much, but this is the science. It's called a polarity behind what we think about that proverbial pendulum swinging. These swings are natural in society and life and business and religion, but back in the 90s, we were really pulled away from doing opioids, and then a bunch of factors pushed the pendulum way too far for the use of opioids and overuse of opioids. Now the pendulum's swinging the other way, and what we're doing at the NIH, I'm going to stick on this slide for a couple minutes, is trying to make sure that as the pendulum swings back, we both help fight the opioid crisis, but we also help people in pain and have them not crushed by this pendulum swinging back. Now, just a few things we're doing at the NIH around pain and opioids. We're trying to first treat both of these problems together, not just focus on the opioid problem or focus on the pain problem. We're trying to fight both of them. One thing we're doing through the NIH Pain Consortium is we've created an educational portal for clinicians in training, and that's we call the Centers of Excellence in Pain Education. We now have 7 online modules. We're trying to help clinicians learn more about how to treat pain, learn more about how to treat the potential of addiction that they'll encounter. Is the most common thing that pain is the most common thing that most clinicians will encounter in their work. Right now, the average clinician gets about 9 hours of training on pain over the course of 4 years of medical school. We're trying to make that better. We also have a national plan. It's called the National Pain Strategy. It came out. It was released the same week as the CDC guideline. I was involved with the development of the CDC guideline, but I also helped develop the National Pain Strategy. If you think of that, the CDC guideline, it's saying, for the most part, use less opioids, use them more reasonably. But the National Pain Strategy is saying, okay, well, you're using less opioids, But here's these other things you can do. And a question came in about acupuncture and things like that and barriers to that. We got to break down barriers to these non-opioid treatments. We got to get more reimbursement for those things. A big event that happened, the NIH now considers the opioid and pain crisis our top priority by far of anything else. It's likened to the AIDS crisis, the priority of the AIDS crisis that stemming from the 80s. The head of the NIH, Francis Collins, had 3 workshops over the summer, and we're pursuing public-private partnerships where drug companies will work with us, the NIH, trying to do things that will help with the pain and opioid crisis. We have 3 committees working on the pain side. One committee, we're trying to get pharma to share their data with each other. They're very secretive. I've got this, you got that. And if they work together, maybe we can come up with better pain treatments and be able to rely less on opioids. And pharma wants to share. There's legal stuff and all that, but they do feel like they should be part of the solution to this problem. So we're developing a pain trial network, and we're also developing biomarkers for pain. Part of our problem in studying anything, the foundation of good science is good measures, and we really don't measure pain well. 0 to 10 scale, a verbal report hurts a lot. That's what they were doing in prehistoric times. So we can do better. Pain is a real phenomenon. It impacts a person on many, many levels, the biological, the social, the psychological, spiritual levels. We got to get some better measures so we can study it better and so we can diagnose it better and treat it better. So I'm thrilled. I'm a pain and opioid guy, and I'm thrilled about all of these things happening at the NIH. But then last Wednesday, the head of the NIH called us into this building that you're looking at. That's Building 1. And the pain people from across the NIH came, and he had an announcement that he wanted to do more than the public-private partnerships. He wanted to look at all sorts of other types of pain treatments, all sorts of other ways to deal with the opioid crisis. And he had met with Congress people, and I kind of fell off my chair, but he said that there'd be $2 billion in new money invested to the NIH on this. That's, as a government employee, we deal with $1 million here, $1 million there, and it's a lot of money, but we don't usually deal with $2 billion for an issue, and we're thrilled that that's coming up. And right now we're scrambling to use that money to get the money, put it in places that really have impact. So a lot going on at the NIH, too much to talk about in this short talk. I have 4 or 5 minutes left. I would like to discuss one alternative to opioids, and it's just an area being recently developed. It's not the answer. I think the answer is not one thing. But since 1999, I've been interested in virtual reality and pain. You put goggles on, and you go to different worlds. How could that be used therapeutically for drug abuse, for pain? I think there's some real potential. This is a mock-up of this is what I saw on my desk. Somebody literally put this journal on my desk, but I didn't take a picture. I recreated for this talk, but fact still remains. It was that little event started me on a 17-year quest to promote virtual reality and pain. A leading researcher in the field, this is Dr. Hoffman. He's treating somebody with burn pains. People with burns, they have to have their dressings changed on a twice-a-daily basis. It's very painful and it's very disturbing, but they put them in these virtual reality outfits. This is a special one that could go in water, and they don't even notice it practically. So that was one encouraging way to use VR. I'm just showing you this. This is Brenda Wiederhold, a pioneer in the area. This is an old head-mount display to see virtual reality set up. It literally has to be held up with a rope. It's heavy. This was 15 years ago. We've come a long way since then. In 2004, we had our first conference on VR at the NIH. That was interesting because we were bringing, at the time, very weird science to the NIH and trying to bring it into the mainstream. There's a number of different ways to use VR. I'm just going to scroll them because I don't have time. But things like you could do meditation in VR. You can use distraction. You could use cognitive behavioral therapy. You can learn coping skills. So all those sort of things can be included. And the big advance, and I'm not promoting any given product, But right now, these head-mount displays, they're cheap. They used to be $40,000, and it was hard to get one in a clinic. Now they're $300, $700. I've got one in my basement, and the Olympics are in VR right now. I haven't gone down to look at them yet, but it's becoming much more accessible, mainstream, affordable. So I think now might be a really good time to keep pushing this field forward. And it always helps when the director of your institute is interested in what you're doing. This is our director in VR last year, kind of very interested in the world. She's very much promoted. It's Nora Volkov. She very much promotes technologies. And then I just want to tell you something about funding. Here's where we were, and these are how many grants were funded in 1995 at the NIH on VR, 2003, 2010. It's really been skyrocketing. So, and in terms of dollar amounts, we're spending a lot of money on this, and this isn't the only thing. We're not spending $2 billion on this, but we're spending a lot of money, and it's across a lot of the different agencies. So this is almost my last slide. I was hoping I'd have a minute left to say one more thing, so you get a bonus slide, if you will. So we're very concerned about opioids, very concerned about pain. But at NIDA, we take across drug abuse. We're not the National Institute on Opioid Abuse. We're the National Institute on Drug Abuse, and we're concerned about other drugs of abuse. So cocaine, if you look at the death rates, this is a paper we just published for African Americans versus whites. African Americans are dying of cocaine at the same rate that whites are dying of opioids. So it underscores that we don't just have an opioid crisis. We have a drug abuse crisis, and we got to fight on all fronts. And that is my last slide. Thank you.